My name is Pieter Sonneveld. I'm a professor of hematology in Rotterdam, the Netherlands, at the Erasmus University and Medical Center. And also, I am the current president of the European Myeloma Network, which runs trials in multiple myeloma with industry partners. And one of those is the PERSEUS trial that is the topic of this interview. So the first author on this paper, the oral presentation, was Dr. Luca Bertamini, who's working in my lab in Rotterdam. Also on behalf of many authors and investigators in the global PERSEUS trial, with many countries contributing in Europe and also in Australia. So Dr. Bertamini presented data on the PERSEUS trial in addition to previously published and presented data on the clinical outcome in the trial. But this time we focused on circulating tumor cells in multiple myeloma because circulating tumor cells in other studies have been associated with worse progression-free survival and overall survival, while patients with low or undetectable CTC levels had better outcomes. The MRD negativity and sustained MRD negativity are also new, let's say, outcome parameters associated with a longer PFS and overall survival. And MRD negativity has become a strong prognostic clinical endpoint in myeloma. Since the CD38 antibodies, including daratumumab, were introduced in the frontline treatment of multiple myeloma, several trials were performed which showed the superiority of treatment arms that included daratumumab. The next question that we had is about the clinical endpoints, MRD negativity and sustained MRD negativity, that, as you will know, were supported by the FDA ODAC vote as an early endpoint partly endpoint for accelerated approval for new myeloma treatments. And then we asked ourselves the question, what is the role and the impact of CTCs as a biomarker in these transplant-eligible patients with newly diagnosed myeloma who were included in the PERSEUS trial? This PERSEUS trial, as just a quick reminder, showed a 55% reduction in the risk of progression or death in patients that were treated with dara-VRd for induction and consolidation compared with VRd, and also received dara-len for maintenance as compared with len maintenance only after VRd. Now you will remember from our presentation at last year ASH and also in the New England Journal publication that the 4-year progression-free survival of PFS, progression-free survival of patients treated with dara-VRd was 84%, and this was highly significantly better than patients treated with VRd with a hazard ratio of 0.42. And also the MRD negativity and sustained MRD negativity were much better in the patients treated with dara-VRd. When we looked at our data, we concluded that CTC testing could be performed in 451 randomized patients on samples collected at registration and before treatment in the CTC trial, and these were equally divided over the VRd arm and the dara-VRd arm. The CTC detection, median detection, was 0.04 cells, and percentage-wise, the median was 0.0094% of the nucleated cells. So we asked ourselves the question, is CTC level and the number of CTCs detected prognostic for the primary endpoint progression-free survival? Now, first we found that there was no difference in the CTCs detected and the percentage of CTC between the two treatment arms. Also not a difference of sex or age, ISS stage, and cytogenetic high-risk group, only a small difference of high LDH with a higher percentage in the dara-VRd group. So overall, patients and the characteristics were well balanced between the treatment groups. Then next, when we look to the varying levels of CTCs, we could conclude that with increasing levels of CTCs, the 4-year progression-free survival estimates decreased from 84% down to 48%. 48% in the patients with the highest numbers and percentage of CTCs. In the multivariate analysis of other risk factors and CTCs, it was clear that CTCs were an independent risk factor for progression-free survival with a hazard ratio of 1.36. In addition, also high-risk cytogenetics, ISS stage 3, were independent prognostic factors, negative prognostic factors. On the other hand, treatment with dara-VRd was a positive discriminating prognostic factor. In fact, we now have a new tool, the percentage of CTCs, to identify patients with a higher risk of progression in the PERSEUS context. Also, when we analyzed the cutoff level and the threshold that could be used for such a difference, we found out that the CTC-high percentage of high CTCs was not different between two treatment arms, and that the optimal cutoff for prognosis was 0.175%, and this had a hazard ratio of 3.5, a highly significant difference between CTC-low and CTC-high across the whole treatment group. And when subdividing for the treatment arms, both in the CTC-low and in the CTC-high subgroups, the PFS was significantly better with dara-VRd treatment in these patients, with a highly significant difference. Then we look to other risk factors like the high-risk cytogenetics, standard risk cytogenetics. It could be concluded that patients with standard risk cytogenetics and CTC-low versus CTC-high had a significant difference. This was also true between the high-risk cytogenetics with CTC-low and CTC-high. Patients with high-risk cytogenetics and high CTCs had a worse prognosis, and this was very significant. Looking further into patients with not high but standard cytogenetic risk, again, what we found is that dara-VRd, both for CTC-low and CTC-high, had a superior outcome compared with VRd, CTC-low, and VRd, CTC-high. So dara-VRd improved outcomes regardless of CTC levels in patients with standard risk cytogenetics. In the high-risk cytogenetics group, we could identify that D-VRd improved outcomes in patients with high-risk cytogenetics and low CTC levels, but not so in patients with high-risk cytogenetic risk combined with high-risk CTC levels. So there is an improvement, but DARA is not completely abrogating the poor risk associated with these high cytogenetic risk and high CTC levels. When looking further into MRD negativity, again, patients with higher CTC levels had a lower level of MRD negativity in both treatment arms, but dara-VRd improved the MRD negativity rates at 10-5 and 10-6 in CTC-high and low patients. So for both groups, there is a benefit. And when we look at CTC, at sustained MRD negativity for 12 months or more, combined with CR or better at 10-5 and 10-6 level, we can conclude that patients with CTC-low do better than CTC-high, but the improvement of sustained MRD negativity is especially clear in the patients that were treated with dara-VRd, both for CTC-high and for CTC-low. In conclusion, the results from this analysis in PERSEUS support the impact of CTC as a biomarker in transplant-eligible patients, and high CTC levels as a prognostic marker are associated with worse progression-free survival independently of other risk factors like cytogenetics, ISS, and LDH. High CTC levels combined with high-risk cytogenetics identify an ultra-high-risk group with the worst prognosis in this total group of PERSEUS patients. Treatment with dara-VRd improves the outcome over VRd in both patients with high and low CTC levels. leading to improved MRD negativity and sustained MRD negativity rates at both 10^-5 and 10^-6 levels and improved PFS. So we conclude that high CTC levels should be considered a risk factor assessed at diagnosis in clinical trials and in clinical practice. And this is especially also true for patients treated with the PERSEUS schedule, D-VRd, since this has now been approved by FDA and by EMA and will enter routine clinical practice soon or has already done so. Finally, we want to thank the patients, the families and caregivers, all the staff members on the study sites, European Myeloma Network, Janssen, and the Department of Hematology and Immunology at the Erasmus in Rotterdam. Finally, I would like to mention that this study was sponsored by EMN in collaboration with Janssen Research and Development and LLC. And of course, Dr. Bertomini, who was the principal investigator on this study. Yeah, so as I mentioned in the conclusion of my talk, dara-VRd for induction and for consolidation, followed by dara-len maintenance, has now been approved by the EMA for routine clinical practice. And what we already see is that large numbers of patients are being treated with this schedule. So if you start a treatment with these schedules, it's important to verify the risk factors before starting treatment. What we did, in addition to a higher ISS rate, LDH and cytogenetics, is now add CTC levels as a new prognostic factor for these patients. So I think the data speak for themselves. It's an important new step in the dossier about CTC as a prognostic factor. And based on this analysis and others in different countries like Italy, Spain, and other countries, there is now an ongoing meta-analysis for large studies which examine the role of CTCs, which will include many thousand patients, in which we hope to establish the new, let's say, standard for CTC cutoff levels and their role in different treatment protocols with different drugs, different treatments, and so on.